Please remember that we are going to talk about cohort 1 plus 2, means 17,162 patients. And most of the other talks will refer to cohort 1, 2, and 3, up to 28,000 patients. Here, 17,000 only, if I may say so. These are my disclosures. And here I listed a certain number of research questions which are actually very simple. What are the rates of major adverse events over the course of the follow-up? Stroke, systemic embolism, major bleeding, and all-cause mortality. What type of stroke and major bleeding events were recorded and how severe were they? What were the causes of death is very important. We are going to spend some time here. And which are the variables associated with an increased risk of stroke, systemic embolism, major bleeding, and all-cause mortality. Sorry. These are the baseline characteristics, nothing really specific. The mean age is in the range of 69, and you may appreciate here that almost 40% of the cohort is made of patients over 75 years of age. But generally speaking, no big, let's say, wonder. The mean CHA2DS2-VASc was 3.3, and the mean Hasbled score was 1.5. And here is a distribution of CHA2DS2-VASc score, and you may immediately see that the vast majority of patients had a CHA2DS2-VASc over 2. In other words, over 2, they all needed anticoagulation. And the Hasbled score, the vast majority of the patients had actually not so high Hasbled score, 1 or 2. Only 11% had Hasbled score 3, which is considered to be, let's say, a high risk for bleeding. I presume that you have seen this kind of slides many times. Here is CHA2DS2-VASc, here is Hasbled, and the treatment at baseline. Please remember that during for the first two cohorts, the anticoagulation treatment was given to roughly 60% of patients, but only 10% of them took new oral anticoagulants. And there is a nice increase in the uptake of anticoagulants with increasing CHA2DS2-VASc. And you may also appreciate that in patients at truly low risk, meaning CHA2DS2-VASc 0, still 40% of patients are anticoagulated, whereas it's not really recommended in the guidelines. Hasbled is basically the opposite. In other words, increasing Hasbled score, then there is a decrease in the uptake of anticoagulants, and we can understand that quite easily. Now, you have seen this slide already, and you have noticed already that the most frequent adverse event is death, 3.83 at 24 months, and slightly higher rate of all three events during the first year compared to the second year of follow-up. And this slide shows you the rate of events according to the CHA2DS2-VASc score. And what is quite interesting is to notice that any kind of event increases with CHA2DS2-VASc score, including bleeding. Bleeding is gradually increasing, as well as stroke, systemic embolism, and, of course, all-cause mortality. And here, it's CHA2DS2-VASc 0. And no doubt, the rate of stroke, systemic embolism is very low, as well as the rate of bleeding. But this is crude rates, but still, the rate of death is not that low. Means that low-risk patient doesn't mean no risk. Remember that. Now, the cause of death is very interesting to consider. Here, in dark, in bold, cardiovascular deaths, 478 patients. Non-cardiovascular deaths, 423. Slightly less non-cardiovascular compared to cardiovascular deaths. But look at the causes. In cardiovascular deaths, 44%, roughly 45% of patients died from congestive heart failure or sudden unwitnessed death. And in non-cardiovascular causes, more than 50% of the patients died either from malignancy and respiratory failure. Why is this remark? Simply because if anticoagulation has an impact on the risk of death, then we can consider that we may reach a limit at a point in time, because congestive heart failure, to the best of my knowledge, sudden death, malignancy, and respiratory failure are not influenced by anticoagulation. Type and rate of stroke during the 2-year follow-up, most of them were primary ischemic, very few were primary hemorrhagic, and in some, sizable number of patients, then the information is lacking simply because the investigators did not know whether a stroke was ischemic or hemorrhagic. Now we come to the most interesting part of the data analysis. In other words, the variables that influence or that are, let's say, associated with the risk. And pay attention, these are adjusted hazard ratio. It's a very busy slide, but we're going to go into detail together. First of all, clearly, in a mixed population with anticoagulation on board, in 60% of them, still, age is the most important factor, has the strongest association with the risk of death, stroke, systemic embolism, and major bleed as well. You may appreciate that all these variables listed here are actually components of the CHA2DS2-VASc score. And see what happens. Women, diabetes, hypertension, no impact on major bleeding, no significant impact on major bleeding, no difference stroke, systemic embolism, and apparently no impact on mortality either, which may be a little bit surprising, but there are some explanations for that. Now, stroke, previous stroke or TIA, major impact on risk of death, stroke, of course, nothing in major bleeding, cardiac failure, major impact on death, and not much, if any, on stroke, systemic embolism, and vascular disease, major impact on death, but not so much on stroke, systemic embolism. Again, these are adjusted data. Now, the other variables are not components of the CHA2DS2-VASc score. And surprise, surprise, no longer a surprise because we heard that from Shinya Goto. The Asians have a lower risk of death. And these are adjusted data we can trust. This is a strong message for us. Now, smoking, huge impact on risk of death. Ex-smokers, current smokers, more particularly. And no impact on stroke, but check it out, excess of bleeding. Surprise, surprise. Actually, it's not really a surprise because this has been described in other settings, and particularly in the setting of acute coronary syndrome and coronary artery disease. But to the best of my knowledge, the first time that we show that bleeding has an impact, smoking has an impact on bleeding in newly diagnosed atrial fibrillation. Renal disease, often neglected by the clinicians. This is by far, with age, the variable most strongly associated with any kind of risk, whatever it is, death, not surprising. Stroke, systemic embolism is more surprising. Major bleed, not surprising. Now, type of atrial fibrillation. For your information, paroxysmal atrial fibrillation is a control group. And you see that in terms of risk of death, permanent, persistent, but also newly diagnosed, new atrial fibrillation is associated with a higher risk, significant higher risk of death compared to paroxysmal. But apparently no difference, irrespective of the type of atrial fibrillation in terms of risk of stroke and bleeding. And now the icing on the cake is anticoagulant treatment. Huge impact on the risk of mortality, 38% less chance of dying with anticoagulant compared to no anticoagulant. Same for stroke, in the range of 38% as well. And of course, no big surprise, there is an excess of bleeding. So these are basically the main messages I wanted to deliver. And to summarize, we are dealing with a mixed population of anticoagulated and non-anticoagulated patients representing real life worldwide. We were discussing more or less the components of the risk scores. But remember, for example, CHA2DS2-VASc was established in a population of patients naive to anticoagulation. So it doesn't necessarily apply to this kind of population. The most frequent adverse outcome is all-cause mortality. Stroke, systemic embolism, and major bleed are far less frequent. Anticoagulants anticoagulation has a striking impact on the risk of both mortality and stroke systemic embolism, but many of the causes of death are uninfluenced by anticoagulation, which means that we may reach a limit at a point in time in the risk reduction for death with the treatment of atrial fibrillation. And again, several variables are strongly associated with the risk of adverse outcomes, but are not integrated in the existing risk scores, and particularly ethnicity, particularly smoking, and particularly renal failure. Thank you very much for your attention.